This is one of the key areas because amyloidosis is a rare disease. Clinical trials are challenging in amyloidosis, and the entry criteria for trials means that all patients can never get into these clinical trials. More crucially, over the last 20 years, a number of large centers have had very large databases of amyloid patients, which have guided our treatments. And certainly, this real-world data has helped to shape treatment and even lead us to the point where these trials are currently being conducted. CyBO-D, for example, which is a regimen of cyclophosphamide, Velcade, Dex, which is now considered as one of the frontline treatments for amyloidosis, emerged from our real-world data set, both from the Mayo Clinic and from our own center, and then it's moved on into frontline clinical practice. The problem with amyloidosis is that the patients tend to be widely scattered, and often access to trials is very challenging. Patients with this disease often have very advanced degree of organ dysfunction, so they fail to meet the entry criteria for trials, which can be quite restrictive. And therefore, the real-world data set will give a true picture of the disease, which is often missed in patients in clinical trials, which, by the very means of selecting a uniform group of patients, means that they are highly selected. We certainly find that in our hands, on a real-world data set, the mortality for patients with cardiac amyloidosis within the first year is anywhere between 30 to 35%, often up to 40%. But when you look at a clinical trial data set, that same mortality will be anywhere down between 10 and 15%.